All right, let's get right into it. When you're in the middle of the trauma bay chaos, the ABCs are everything. So you've secured the airway. Now what? We're going to do a deep dive into B, breathing, from the ATLS primary survey. This is all the critical stuff you're going to need, not just for your final exams, but for when it really counts.
Okay, let's start with this one sentence. Honestly, this is the whole foundation for everything we're about to talk about. It's the core principle of B for breathing. You can have a perfectly open, patent airway, but if your patient isn't actually moving air in and out, well, you're still on the fast track to a disaster. So here's how we're going to tackle this. We'll walk through it just like a real trauma scenario. We'll start with why breathing is the priority, then move to spotting those immediate life threats and dealing with thoracic emergencies. After that, we'll get into the tech we use for monitoring, why you can never stop reassessing, and finally, touch on how things change for special patient populations. Okay, Section 1, the priority of breathing. You've just sorted out A for airway. The immediate next step is B. So when we say assess breathing, what are we actually looking for? What does that really mean?
Here's the absolute key. Ventilation is not just about the lungs. You got to think of it as a whole mechanical system. The lungs, yeah, but also the chest wall and the diaphragm all have to be working together. And in trauma, a breakdown in any one of those parts can cause the whole system to fail catastrophically.
All right, your first look at breathing has to be lightning fast and just ruthless. You're on a search and destroy mission. You're hunting for the injuries that are going to kill your patient in the next couple of minutes. This is no time for a slow, thoughtful differential diagnosis.
These right here, these are the 5 big killers you have to find during that primary survey. These are the absolute cannot miss diagnoses. We're going to focus in on the most common emergencies that you have to recognize and act on right now. So let's get into those critical emergencies. For your exams, and way more importantly in real life, this all boils down to pattern recognition. You see the problem, you fix the problem. Simple as that. Let's break down the big ones. The tension pneumothorax. This is the classic mechanical emergency. You've got air getting into the chest, but it can't get out. It's a one-way valve. And this isn't just a breathing problem. That pressure builds and builds until it crushes the heart and great vessels. So it's a circulatory problem too. It takes out B and C at the same time. And this right here, this is the exam critical pairing you have to burn into your brain. If you see this set of signs, the patient can't breathe, you hear no breath sounds on one side, and their blood pressure is tanking, your hand should already be reaching for a big needle. This is a clinical diagnosis. You absolutely do not wait for a chest x-ray. Okay, next up, massive hemothorax. For this one, I want you to think of it as 2 problems at once. First, it's a massive bleed, a volume problem. But all that blood is also filling up the chest cavity and crushing the lung, a space problem. So the picture you'll see is a patient in shock who also has absent breath sounds on one side. Your job is twofold, and you have to do both at once. Pour in fluids and blood to replace what they've lost, and at the same time, get a huge chest tube in to drain all that blood out. With an open pneumothorax, or a sucking chest wound, the basic mechanics of breathing are just completely broken. You've got a hole in the chest wall that's so big, air just goes in and out through the hole instead of down the trachea. Effective breathing becomes impossible. The great thing here is that you diagnose it just by looking. You see the wound. And the immediate fix is beautiful in its simplicity. You slap on an occlusive dressing and tape it on only 3 sides. That creates a little one-way flutter valve, turning that open pneumo into a closed one and letting the lungs start to work again. Okay, so you found and traded the immediate killers, but you are far from done. Now we've got to talk about the tools that help us keep an eye on our patient and figure out if what we just did is actually helping.
Yeah, the pulse oximeter. You're going to see one on every single trauma patient, and for good reason. It's a vital tool. But, and this is a huge but, it can lie to you. For your exams, you have to know its limitations. Knowing when not to trust it is just as important as knowing what it does.
And this slide hits the high points. First, it only tells you about oxygen saturation, not ventilation. It tells you nothing about if the patient is clearing CO2. Second, and this is a classic exam question, with carbon monoxide poisoning, the oximeter can read a perfect 100%. That's a deadly, false sense of security. And finally, a patient can be on the verge of desaturating with almost no oxygen reserve, but the SAT will still read 100% right up until the moment they crash. You know, this might just be the single most important concept in all of trauma care. Putting in a chest tube or giving fluids isn't the end of the story. It's the beginning of the next chapter. You have to constantly go back and verify that your treatments are working. This quote from the manual, you should never forget it. Our best monitor, our most sensitive piece of equipment, isn't a machine that beeps and flashes. It's our own eyes, our ears, and our hands, doing a good physical exam over and over again. Don't ever let the technology distract you from the actual patient. So after every single thing you do, you place a chest tube, you hang a bag of fluid, anything, you have to go right back to the basics. Look, listen, and feel. Did the breath sounds come back? Is the chest rising evenly now? Is the chest tube actually draining anything? You have to close the loop every single time. Okay, finally, let's talk about adapting your plan. The ATLS algorithm is an amazing guide, but it's not a rigid rule book. It's not a one-size-fits-all solution. You have to use your clinical judgment, and this is especially true when you're dealing with special populations. And this slide gives two perfect examples of what I mean. On the left, you've got an obese patient. That standard little needle you use for decompression, it might not even get close to the pleural space. You have to adapt your technique. And on the right, you have an older patient. For them, a few broken ribs isn't a minor injury. It's a huge deal that can easily lead to pneumonia and even death if you don't aggressively manage their pain and their breathing. So if there's one thing you take away from this, let it be this. Managing B for breathing isn't a box you check and then move on. It's a continuous, dynamic cycle. You're constantly assessing, intervening, and then reassessing the response, over and over again. And that leaves us with the next big question. You've managed B, you've got their breathing sorted out for now, but what if they're still in shock? What if their pressure is still low? Well, that leads us directly to the next critical step in our primary survey. C for circulation.